So the Kiel Cardiovascular Research Group conducted a population-based cohort study to assess the outcomes of acute myocardial infarction presenting with out-of-hospital cardiac arrest in patients admitted between 2010 and 2017. Of the 16,278 patients admitted in this period, women constituted almost 1/4 of the population. Women were less likely to survive following out-of-hospital cardiac arrest. Women were also less likely to receive coronary angiography and bypass surgery. Women were older, experienced longer call to hospital arrival time, and were less likely to present with a shockable rhythm. These factors are known to be associated with poor prognosis in out-of-hospital cardiac arrest. We also assessed the differences in the hospital management between men and women. I am Mohammed Dafala. I am an academic cardiology registrar at Keele University and West Midlands Deanery in England, United Kingdom. I would like to thank Mayo Clinic Proceedings for having me today to speak about our article that's going to be published in Mayo Clinic Proceedings Journal in September 2022, titled "Women are less likely to survive acute myocardial infarction presenting with out-of-hospital cardiac arrest, a nationwide study." The source of the data was the national registry that is called Myocardial Ischemia National Audit Project Registry, which in short it's called MyNAP Registry. Regarding the clinical outcomes, the primary outcome of interest was the in-hospital mortality. The secondary outcomes were reinfarction, major bleeding, use of coronary angiography, and inpatient myocardial revascularization by either bypass surgery or PCI. Our study shows that women have low odds of survival following out-of-hospital cardiac arrest. We noted that women were less likely to receive evidence-based medications like dual antiplatelet therapy, beta blockers, angiotensin-converting enzyme inhibitors. Women were also less likely to receive myocardial revascularization. This was driven mainly by the lower use of bypass surgery in women. There was no significant difference in the odds of reinfarction and bleeding. So, if we have a look at the sex disparities in cardiovascular diseases, sex disparities in management and outcomes of acute myocardial infarction were reported early on by early landmark studies in the 90s. It was found that physicians pursue less aggressive management approach to coronary artery disease in women, despite of the more significant cardiac disability. The impact of sex in out-of-hospital cardiac arrest in patients with acute myocardial infarction on the clinical outcomes is still a cause of discussion, with several studies reporting conflicting outcomes. Several studies report that sex is not an independent predictor of mortality. However, there is growing evidence that women have poor outcomes compared to men, not because of the patient sex itself, but because of the differences in patient characteristics, pre-hospital management, and inpatient management. So when it comes to out-of-hospital cardiac arrest, the clinical outcomes depend on what is called chain of survival. The chain of survival begins by early recognition of out-of-hospital cardiac arrest in the community, activation of the emergency response system, cardiopulmonary resuscitation, defibrillation, advanced life support, transfer to hospital, and then post-resuscitation care. So there are two main points I would like to discuss here to highlight why there is a difference in the survival between men and women. The first point is related to the pre-hospital setting, namely the early CPR. It's been reported that by CPR rates are far lower in women compared to men. In fact, bystanders and emergency medical personnel may be reluctant to expose women to place monitor pads on the chest, which may lead to delay in cardiac rhythm analysis and defibrillation. In fact, national data from US showed that bystander CPR much significantly lower in women compared to men presenting with out-of-hospital cardiac arrest. The second point that could explain the poor outcomes is the difference in the in-hospital management, namely the differences in rates of coronary revascularization. One of the reasons that could be behind the difference in the utilization of bypass surgery and PCI in women could be the unconscious bias among physicians that affect their decision making. It's been reported that physicians may have an unconscious bias against women, which may lead to lower rate of utilization of invasive therapy. In fact, in a computerized survey of physicians who were faced with clinical scenarios of chest pain with actors representing combinations of race, sex, and age, women were 40% less likely to be referred for cardiac catheterization than men, even after adjusting for the potential confounding factor. So these 2 points are the main points we think could possibly be behind the differences in the in-hospital management and clinical outcomes of out-of-hospital cardiac arrest. So the next question will be, how does this finding relate to the clinical practice, and what should we do next then? So this study augment the growing evidence that women are at higher risk of in-hospital death following out-of-hospital cardiac arrest. So what we can do is we can address the 2 points I explained earlier. So first point, we can address the pre-hospital setting and encourage people to treat out-of-hospital cardiac arrest in women as they do in men. So public media campaigns to encourage the public to act as soon as they identify an out-of-hospital cardiac arrest may increase the awareness of the public and encourage bystanders to do CPR as soon as they recognize an out-of-hospital cardiac arrest. Education and training of emergency medical personnel will probably improve the identification of AMI symptoms and allow early recognition and earlier treatment of out-of-hospital cardiac arrest. Regarding the hospital setting, we need to identify why exactly women tend to receive lower revascularization therapy. We need to make sure that there is no unconscious bias against women. What we can do is we can apply protocols and policies that make sure that decisions regarding revascularization have clear standards and clear criteria rather than on subjective assessment of the physician alone. We can also encourage physicians to and teach them and educate them about these discrepancies to make them aware of these discrepancies, encourage them to act without bias against women. So finally, I would like to thank Mayo Clinic Proceedings for accepting our paper for publication. I would like to thank the media team and the YouTube channel team for having me today. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.